We ready to go?
Right, good afternoon. It's Monday, 25 August. Welcome to G Echo. It is hosted by the Gastro Foundation in association with Project Echo, University of New Mexico. G Echo Fellows, it runs every 2 weeks, as you know, on a Monday, 6 o'clock. I'm Christo Kloppers. I will be chairing this session, and I'm with Lillian, Musyoka, and we're going to talk today on liver abscesses and cystic liver disease. I hope she's going to be here with us soon. We had a little bit of trouble with connecting. Lillian, are you here? Oh, there you are. Sorry. Okay, good. The floor is yours. Thank you very much. We're looking forward to your presentation. You guys can leave questions in the chat box, and we'll see at the end how we can address them. Thank you. Thank you, Lillian. Can we share a presentation?
Okay, I'll be sharing from my side. Lillian, are you okay?
Yes, I am.
Okay.
Kindly put them on slide share. That's great.
Just ask me to
Sorry.
next slide, when you're ready.
Okay. Sorry for that technical itch. My name is Lillian Musyoka. I'm a medical gastroenterology fellow at Steve Biko Academic Hospital. So today I'll be taking you through an overview of liver abscesses and liver cystic disease. It's a wide topic. We'll try and emphasize on the more common conditions that we see in our everyday practice. So this will be the outline of the presentation. We'll go through the WHO classification, and this is the 5th edition. Then we'll tackle each one of the conditions one by one in that order. Next. So the WHO classification classifies cystic liver lesions in either epithelium lined or non-epithelium lined. The epithelium lined, those without epithelium lining can be classified as either neoplastic, which can either be benign or can be malignant, and can also be inflammatory. Next. The non-neoplastic ones can be classified into those with laminated wall or the ones with inflammation and necrosis. Today we'll focus on the inflammation and necrosis, and we'll talk about next the pyogenic liver abscesses, the amoebic liver abscesses, and the hydatid cyst. Next. Next, please. Next. Next. The epithelium line can either be lined with a cuboidal, low columnar epithelium, and in this group we have either the solitary bile duct cyst, the fibropolycystic liver disease, the obstructive dilatation of the bile duct, and in this category we'll focus on the fibropolycystic liver disease. They can also be ciliated, whereby we have the ciliated foregut cyst. Then we have the biliary mucinous or oncocytic cyst. And in this category, it can either be with ovarian-like stroma or without ovarian like stroma. In this category, we'll focus on the mucinous cyst neoplasm. Next. Next. Next, please. So we'll start our presentation with pyogenic liver abscesses. Kindly go behind. So the pyogenic liver abscess and abscess is kindly go back 2 slides. Back.
I'm not sure what you're seeing, Lillian. How far back do you need me to go?
Lillian, at the moment, we're seeing still the classification slide. We're not at the pyogenic liver abscess slide. You had a slide there on pathophysiology, but it's not on that. What do you see?
I think she just froze. We lost her.
I think that let's just move forward to that slide of the pyogenic abscess. If she comes back, yeah, there. Hopefully she'll come back soon. Maybe while we wait, I can ask the participants if there's any questions around the classification she lined up. I know it's not really clinical classification or comments.
Sorry, Professor Christo, I'm back online.
Good, no
I
problem.
hope this won't happen again.
No, listen.
I've disabled my video.
Collect your thoughts first. Can you see the pyogenic liver abscess slide now?
Yes, I can.
Okay, good. I'll keep quiet.
Okay, sorry about that. So the pyogenic liver abscess, they are localized collection of pus within the liver tissue. This is a rare condition occurring in 2.3 persons per 100 person in the USA and being more common in the East Asia, whereby it occurs in 17.6 persons per 100,000. We don't have local data in the sub-Saharan Africa on the prevalence of this condition. It's higher in male, being almost 3 times more common in male compared to females, and it can occur as a result of either secondary spread from biliary disease, portal-pyemia, or various causes, arterial hematogenous seeding, or through direct spread of infection of the organs near the liver. So there is a schematic presentation to demonstrate that. Next. Some of the risk factors of developing pyogenic liver abscess include diabetes mellitus, hepatobiliary disease, pancreatic disease, whether benign or malignant, liver transplant, chronic use of PPI, geographic location in whereby it's commoner in East Asia compared to any other part of the world, and colorectal cancer. It's been noted that in retrospective studies, there is a high chance of diagnosing colorectal cancer in patients who have had liver disease, and this is most common 3 months after the treatment for liver abscess. And it's recommended that we screen for colorectal cancer in patients with liver abscess who don't have any other identifiable risk factor. Next. Locally, There has been a study which was done in Johannesburg, that is in Chris Annie and the Charlotte Masheke, which showed that just like is seen in worldwide, most abscesses are polymicrobial. E. coli and Klebsiella are the commonest species isolated, and this is the case worldwide, and a study done in GSH in Cape Town also showed similar studies. 48% of patients have associated biliary pathology, 77.4% of the amoebic, and 9.1% were IDAT disease. Next. Next, please. The typical clinical presentation features of pyogenic liver abscess is that of fever and abdominal pain. Other features include nausea, vomiting, anorexia, weight loss, and malaise. In approximately half of the patients will either have right upper quadrant tenderness, hepatomegaly, or jaundice. In less frequently, you will see right pleural effusion, ascites, and you might have a positive muffin sign and hypotension. When lab tests are done, they are non-specific, and this includes elevated bilirubin, alkaline phosphatase, and a low
Prof, we're not having much luck. She just dropped off again.
Yes. Listen, I think maybe I can read through the slides. I'm not sure how valuable that is. Alternatively, we must have some discussions, some clinical discussions, if there's questions or comments from the participants. No. Okay. Listen, I must admit, obviously, I'm not prepared to talk, but I can read through the slides and see how we go until she comes back. Let's go to the next slide.
modalities that are used. CT scan and ultrasound are the first choice of imaging. And the CT has a higher sensitivity of 95 compared to 85% of the ultrasound. And the ultrasound features range from either hypoechoic to epicoic lesions with internal echoes reflecting debris or septation. The CT will show a well-defined round lesion with central hypoattenuation and can also be more complex with loculated subcollections or an irregular border. Amoebic abscesses and pyogenic abscesses cannot be differentiated on imaging accurately, and for that reason, you need to do further testing to differentiate the same. There is the role of aspiration, which can either be CT or ultrasound guided for obtaining sample for gram staining and culture, and also for drainage of the abscess, depending on the size of the abscess. Next. Next, please.
It's this image.
This is an image showing a CT of the upper abdomen, and you can see on the first image there is a large gas containing abscess in the right lobe of the liver, and on the second image you can see the septation, while on the third image you can see the perilesional edema demonstrated with a solid arrow. Next. Next, please.
Medical management's on the screen.
Yes. So the medical management includes should contain a cover for streptococci, enteric gram-negative bacilli, and anaerobes. It should also cover entamoeba histolytica until the causative pathogen is found or amoebic abscess is excluded. And the treatment should be initiated even before the aspiration is done. The preferred regimens include a third or later generation cephalosporin plus metronidazole, piperacillin tazobactam, with or without metronidazole once entamoeba histolytica has been ruled out. Another regimen that can be used is ampicillin, gentamicin, and metronidazole. However, this regimen should be changed to within 72 hours because of the gentamicin in the regimen. The duration of the treatment range depends on the response to drainage, and it's 2 to 4 weeks intravenous once you have good response, or 4 to 6 weeks intravenous regimen if duration should range from 4 to 6 weeks. Next. Next. The management with single unilocular abscess, which is less than 5 centimeters, percutaneous drainage with either catheter placement or needle aspiration is acceptable. When the lesion is more than 5 centimeters, then there should be placement of a catheter. When you have multiple or multiloculated abscesses, the decision is based on a multidisciplinary team, depending on the expertise of the surgeons, the radiologists, and other underlying condition, and the comorbidities of the patient. Surgical drainage, which can either be laparoscopic or open, may be needed if there is inadequate response to percutaneous drainage after 7 days, or in patients who have abscesses with viscous contents that obstruct the drainage catheter. This may also be considered for accompanying biliary disease or intra-abdominal tumors. The outcome of pyogenic liver abscesses in East Asia, where it's been studied extensively, is 2 to 12% mortality. And the risk factors for mortality include being female, the need for open surgery for management, having a concomitant malignancy, liver failure, and anaerobic or an enterococcal. Next. Next slide.
Okay. Okay, we lost her again, Prof.
Listen, I think Lillian, if you join again, maybe I must just talk a little bit through it, and then we see how we go, and we can see how much of the slides we can get through. I see there's a question: is any pyogenic liver abscess for drainage? No, I don't think so. I think in the surgical world, we call abscesses less than 2 centimeters micro abscesses, and although it's not that big, so certainly smaller than 2 centimeters, we would not consider draining them. And it's also a lot dependent on location. So like anything we do in medicine, you have to weigh the risk versus benefit. So if it's accessible percutaneously without too much difficulty, obviously your threshold for drainage is uh, is helpful. Sometimes if you can't drain them, what is also helpful is just aspiration, because then at least you can send them the content for microbiology and tailored antibiotic therapy. So in a long way around, not all liver abscesses for drainage. You can go to the next slide, please, and then we talk through amoebic liver abscesses. I can give some thoughts on it. Okay, so the presentation of these, as you probably know, is either subacute, but I would think more likely a chronic presentation. And there's a range of symptoms, right? Upper quadrant pain, fever, cough, malaise, weight loss, anorexia, and hiccup. Hiccup would be secondary to diaphragmatic irritation. And there could be GIT symptoms, as it could be in the background of colitis. Next slide. Similar presentation to HIV. Lab tests, leukocytosis with eosinophilia, elevated transaminases, positive antigen and serology testing. For me, sort of a subtle sign for amoebic abscesses is sometimes just a low HP will give you an idea. Imaging, I think she sort of touched on the imaging of pyogenic abscesses, but in amoebic abscesses, you often find this peripheral edema around the mass. It's a hyperechoic, non-heterogenic mass normally, with a peripheral sort of edema and an enhancing rim. Chest X-ray, I think, would be very subtle. Okay, next, and this is the huge abscess. I'm not sure whether Lillian is on, but she must tell me if she. There you can see nicely on that image B, the peripheral sort of enhancement of that edema, pericystic edema. How do they call it? Well, they're centrally liquefied. Okay, next slide.
And then,
Drainage. Lillian, you're back.
yes, I am.
Okay.
So the drainage.
We had drainage of amoebic abscesses.
Sure. So the drainage of amoebic abscess is both diagnostic and therapeutic, and needle aspiration and ultrasound OCT guidance, with or without insertion of pigtail, is recommended. It drains acellular, proteinaceous debris and a brown fluid likened to uncoffee paste. Trophocytes are seen on microscopy of the aspirate in less than 20% of the cases. And antigen and PCR testing increases diagnostic yield. The indications for drainage with a pigtail include a cyst that is more than 20 centimeters in diameter, imminent risk of rupture, which is more common in the left lobe lesions, and clinical deterioration or lack of response to empiric therapy, and exclusion of alternative diagnosis when suspected. The timing for removal of a drain is when the size of the residual abscess is less than 3 centimeters, improvement in abdominal pain, no fever in 48 hours, and when you have an output of less than 10 ml per 24 hours for 2 consecutive days with improvement of leukocyte count. Next. So the medical management is that of sequential treatment, and it started even pending stool and antigen testing when the suspicion of amoebic abscess is high. So the tissue agents used is metronidazole, which is 500 to 750 milligrams per oral 3 times a day for 7 to 10 days. And an alternative is tinidazole, 2 grams, once daily for 5 days with a more than 90% cure rate. An alternative is nitazoxanide, 500 milligrams, twice daily for 10 days. Sequentially, a lumino agent, which is paromomycin, is given 3 times a day, 25 to 30 milligrams per day for 7 days. Another alternative or lumino agent is dihydroxyquine, 650 milligrams orally, 3 times daily for 20 days for adults, and per weight-based kilograms in children. Other alternatives include diloxanide furoate. Next. In pregnancy, metronidazole is still preferred in severe disease, though safety studies are lacking on its safety, and an alternative is chloroquine, 600 milligrams for 2 days, followed by 300 milligrams for 3 weeks, and then use of paromomycin. The outcome of amoebic abscess is less than 1% mortality in uncomplicated disease. Next. Next, we'll move to liver cysts, and here we will start with the more common seen, which is hydatid cyst. Next. So hydatid cyst is caused by a larval stage of the cystod, which is Echinococcus granulosus, and humans are accidental in intermediate hosts and become infected by ingesting parasite eggs, often through either contaminated food, water, or soil, or through contact with infected animals. It's prevalent in rural and underdeveloped areas, especially where people raise livestock and have close contact with dogs. Next. So this is adopted from the CDC website, and as you can see that humans have an accidental host, and the most important interaction here is whereby the farmers or pastoralist communities feed their dogs, which are used as guard dogs, the internal organs of the slaughtered animals, which keeps the cycle continuing. Next. So the clinical manifestations, most of the patients will be asymptomatic in up to 50% of the patients, and the symptoms depend on the size and site of the disease, remembering that it's not only in the liver whereby you can have echinococcus, you can have cysts in the lungs, brain, muscle, kidneys, bone, heart, and the pancreas. And in the right liver lobe, where it's most common, symptoms arise because of the pressure symptoms and may present with right upper quadrant pain, nausea, and vomiting. These symptoms are rare when the cysts are less than 10 centimeters. You can also have pressure or mass effect on the bile ducts and the portal and hepatic veins and the inferior vena cava with resultant cholestasis. You can also have portal hypertension, venous obstruction, and presenting with bad Chiari syndrome. With rupture, it can result into peritonitis, allergic reaction, which can result into an anaphylactic spread. Once there is rupture, you can also have spread to other abdominal organs. Secondary bacterial infection can also occur, leading to pyogenic liver abscesses. Next. So the diagnosis on the laboratory workup, you will have non-specific leukopenia or thrombocytopenia with mild eosinophilia and non-specific liver function abnormalities. The mainstay of diagnosis is imaging and serology, with antibody tests having higher sensitivity tests compared to the antigen testing. The aspiration of cyst for diagnosis is controversial due to the risk of anaphylaxis. Abdominal ultrasound has a sensitivity of 90 to 95%, and you'll see an anechoic small round cyst, which is very similar to the simple cyst that we will look at later. And if they have daughter cysts, it will give the characteristic septation, which we'll see in a few moments. Shifting the patients during ultrasound may demonstrate hydatid cysts, which consist of predominantly ooklets and scolex from the protoscolices. CT helps define the features, especially if you have a calcified wall and you want to determine whether it's an active cyst or not. MRI can define the cyst better, but it's insensitive to the calcification, which is a key marker of inactive cyst. Next. So there is the ultrasound classification of hydatid cysts, which is very important because this is what is used to determine the modality of treatment to be used. The first one is the cystic lesion, which is an undefined lesion. You cannot really tell whether it's a simple cyst or it's an hydatid cyst. Then there's the active cyst, which is the CE1, which shows a snowflake sign. And then we have the CE2, which shows the honeycomb sign from the septation of the daughter cells. Then we have CE3, which shows the water lily sign. This is a transitional zone between the active hydatid disease and inactive hydatid disease. The water lily sign is from floating membranes from the daughter cells. Then there's the CE4, which is an inactive cell, which is a ball of wool sign. This is as a result of hypoechoic and hypoechoic internal contents. And then we have the inactive cyst, which is a calcified shell as a result of a cyst within a solid and calcified cyst. Next. So as I mentioned earlier, the classification determines the mode of management of the cystic echinococcus. So the CE1 and CE3, which is less than 3 centimeter, the mainstay of treatment is albendazole. For the CE3, CE1 and C3A, which is more than 5 centimeter, but less than 10 centimeter, then you have a pair, which is percutaneous aspiration, injection, and reaspiration in combination with albumin. Those with more than 10 centimeters, then it's percutaneous, the pair treatment is the preferred treatment. For CE2 and CE3B, less than 3 centimeter, just like in the CE1 and CE3A, treatment is albendazole. When more than 5 centimeters, then surgery and albendazole are the preferred treatment. The main difference in these two categories is whether you have daughter cells or you don't have daughter cells, which is the main difference between the CE1 and CE3M. The inactive cysts, the main, that is the CE4 and CE5, there is no treatment required, but watch and wait. And when you have multiple cyst stages, then management recommendations are individualized. Next. This is a write-up of what we just discussed. The dosage of albendazole is 15 milligrams per kg per day with a maximum dose of 400 milligrams twice daily. And it's recommended to take it with fatty food, which increases absorption. There's no cutoff. There's no well-defined studies on what duration of treatment is optimal, but treatment of up to 6 months is recommended. Some of the adverse effects of albendazole in those doses and that long duration include hepatotoxicity, cytopenia, alopecia, and you should be on the lookout for that. And you need to monitor the LFTs and the CBC weekly in the first 3 months of treatment. Other alternative treatment include praziquantel, mebendazole. Next. So we mentioned about PAIR, which is puncture, aspiration, injection, and respiration with a colicidal agent, and the main agent used is ethanol. It's done under ultrasound or CT guidance. This treatment is not recommended if there are biliary fistulas present or there is any communication with the biliary tree. There are other modified catheterization techniques that can be used to remove the entire endocyst and daughter cells from the cyst cavity, which uses a large bore catheter and cutting devices together with an aspiration apparatus. And all these treatments are used in combination with albendazole. Next. Surgery is a treatment of choice for ruptured cysts, cysts with biliary fistulae, cysts compressing vital signs, and cysts with secondary infection or hemorrhage. The cysts are removed intact, and albendazole preferred over praziquantel should be started at least 1 week pre-op and continued for at least 4 weeks post-op, and a longer duration is recommended in the case whereby there's a spillage. ERCP required when there is cholestatic jaundice and cholangitis, and sphincterectomy is done with removal of membranes and cysts. When you have external biliary fistula, then stenting is done. When you have a stenosis of the sphincter of Oddi, then sphincterectomy is done. And then bile duct stricture, you can do balloon dilatation and placement of a temporary stent. You need follow-up of patients treated with cystic echinococcus because it's been shown to recur years of treatment. A treatment follow-up of up to 5 years is reasonable. Next. Some of the other causes of infectious liver abscesses and cysts include mycobacterium, which in our setup whereby TB is common should always be part of your differentials. Others include Candida and fasciola, which is a parasite infecting the liver. So when your patient is not responding to either of the treatments, then you need to widen your differential diagnosis to include these other possible causes. Next. Now we move on to hepatic cysts, which from the classification that we started with, these are liver cysts which have an epithelial lining. So hepatic cysts are fluid-filled lesions which are lined by a single layer of epithelium. They are congenital, they are rare, and result from abnormal development of the embryonic ductal plates. It's usually an incidental finding on imaging, and they are symptomatic in 15% of patients. We will start with simple cysts, which are congenital, and they have no communication with the intrahepatic biliary tree. They are more common in females compared to males. And the symptoms when present include abdominal pain, early satiety, nausea, and vomiting from the mass effect. The complications of simple hepatic cysts include infection, hemorrhage, and rupture. And this is rare. The rupture is rare, but is more likely to occur when the cyst is more than 10 centimeters. You can also have a compression of adjacent organs, which include the bile ducts, with resultant increased alkaline phosphatase and jaundice. Next. So the diagnosis of simple cyst is done using ultrasounds and has a sensitivity and positivity of 90%. And what you'll see is an anechoic content with posterior enhancement. They can be either solitary or multiple, and the architecture is can be simple versus complicated versus complex. Complicated and complex cysts are defined by presence of calcification, septations, mural thickening or nodularity, debris containing fluid, hemorrhagic proteinaceous content, fluid levels, wall enhancement, and association with duct dilatation. in which case further imaging with either MRI or CT is required to guide intervention and surveillance and to rule out other forms of liver cyst. Next. So this is an image showing a liver cyst. The first one is a CT image showing a simple hepatic cyst with an hypointense lesion, while on the right we have an T2 weighted MRI image showing a simple hepatic cyst, which is hyperintense in this the T2 image. Next. So the management is that when they are asymptomatic, they are left alone. When symptomatic, then you have volume reducing therapies, and this include percutaneous aspiration with sclerotherapy. However, there is high recurrence rate when this modality is used. We also have cyst fenestration, which is done under laparoscopy with drainage of the cyst wall excision. The recurrence here is less than 8%. When you have multiple large cysts, then partial hepatectomy and fenestration can be done. However, the mortality rate when this is undertaken is as high as 14%, and liver failure may occur with need for liver transplant. The aim of all these management modalities, whichever one is chosen depending on the patient, is symptom relief and not volume reduction. Next. Some of the complications of simple cysts include hemorrhage, and when that occurs, you apply a conservative management approach. You avoid intervention during the active hemorrhage. If the patient is on any anticoagulants, they may need to be interrupted depending on whichever one the patient is on. When cyst infection occurs, then fluoroquinolones or third generation cephalosporins can be started. Next. When you have more than 10 cysts, then the diagnosis of polycystic liver disease is entertained. And this is as a result of either the autosomal dominant polycystic kidney disease or autosomal dominant polycystic liver disease. The autosomal dominant polycystic kidney disease is when you also have concomitant polycystic kidney disease, and these are linked to distinct gene mutations. However, both have an autosomal dominant transmission and almost identical clinical causes. Also to note is that 1/3 of patients with isolated polycystic liver disease may also have a few kidney cysts, either one or two, as does the general population of adults. So you have to consider the age of the patient and the number of cysts and whether they fit the diagnostic criteria of polycystic kidney disease. Next. So just as the simple cysts, most are asymptomatic. When there are symptoms, they tend to be more common in females, in patients with a large number of cysts. Abdominal pain and discomfort, postprandial fullness with hepatomegaly and dyspnea are the commonest symptoms. Severe pain may occur, and when this occurs, you want to suspect an infection, intracystic hemorrhage, rupture, or a pentagulated cyst torsion. Jaundice may also present in this case. Some of the complications include ascites, hepatic hydrothorax, portal hypertension, and rarely can have varices. Next. The diagnosis, the lab works, the LFTs tend to be normal, or you can have a mildly elevated alkaline phosphatase with a elevated gamma GT. CA19-9 may be elevated, however, it's not diagnostic. Ultrasound, CT, and MRI are the mainstay of diagnosis, and they will, in polycystic liver disease, they will appear as multiple hepatic cysts with the same features as simple solitary cysts. For patients, the KDIGO guidelines recommend that you have an abdominal ultrasound for all patients diagnosed with autosomal dominant polycystic kidney disease. However, in patients who have polycystic liver disease, screening is not recommended unless the patients present with symptoms. The liver volume increases marginally by 1.8% in male and 4.8% in females. So when the increase is more than that, then you need to get concerned and intervene. Symptomatic patients need management in expert centers, and there's little room for genetic testing of the genes that predispose to these two conditions. Next. So the GGOT classification is used to classify and assess the severity of polycystic liver disease. Type 1 patients have a limited number, that is less than 10, of large cysts with large areas of non-cystic parenchyma. While in type 2, they have diffuse involvement of the liver parenchyma by medium-sized cysts with remaining large areas of non-cystic parenchyma. While in type 3, patients are characterized by massive diffuse involvement of liver parenchyma by small and medium-sized liver cysts, and only a few areas of normal liver parenchyma. Next. So the management, the non-symptomatic patients, they are left alone. In patients who have numerous small to medium-sized cysts throughout the liver, somatostatin analogs are used. This one is either lanreotide or octreotide. Patients with large or strategically located cysts, percutaneously accessible, then aspiration with sclerotherapy is used. Patients with single or multiple large superficial cysts, then you can do cyst penetration. When you have small to medium cysts clustered in a few segments in the presence of some less affected liver sacs, then liver resection can be considered depending on the different patients. When you have massive polycystic liver disease, severely affecting quality of life or accompanied by recurrent complication, then transplantation can be considered. Next. This is the criteria for considering these patients for liver transplant. We can have a look at them later. The slides are shared. Next. The next cystic liver disease we are going to look is the Caroli disease. So the Caroli disease is the type 4 choledochocysts on the Todani classification. Next, whereby you have multiple intrahepatic ducts, and this results from failure of proper remodeling and resorption of the ductal plates during fetal development. It's referred to Caroli syndrome when you have concomitant congenital liver fibrosis and kidney cysts, which occur in the collecting ducts and distal tubes, in addition to type 5 biliary dilatations. They are thought to be a phenotype of autosomal recessive polycystic kidney disease. The prevalence of cholangiocarcinoma in Caroli disease and syndrome is 7% compared to the 0.05% in general population. And that's why this condition is of importance. And this is thought to be as a result of carcinogenic effect of recurrent cholangitis, cholestasis, and irritation from gallstone. Diagnostic accuracy for cholangiocarcinoma is highest with MRI, and annual screening is recommended once the diagnosis has been made. Next. The clinical features result from cholestasis leading to stone formation, cholangitis, and abscess formation. When liver fibrosis is suspected, it can be assessed by non-invasive methods. Portal hypertension and its complication can result And cholangiocarcinoma, as you said, the risk is up to 7%. Renal involvement may involve fusiform dilatation of the renal collecting ducts and distal tubular renal impairment in patients with Caroli syndrome. Next. This is an image showing the intrahepatic biliary cystic dilatation. Next. So the management involves cholangitis, use of antibiotics and ERCP as per guidelines in patients who get cholangitis. All patients, just like in patients with primary biliary cholangitis, are put on ursodeoxycholic acid at a dosage of 13 to 15 milligrams per day. If abscesses develop, then drainage is done. And as clinicians following the patients, we also need to be cognizant of the possibility of osteoporosis as a result of cholestasis. Liver resection relieves symptoms, particularly in patients with Caroli disease with restricted bile duct involvement. Liver transplant may be considered if patients have recurrent cholangitis, and if it's bilobar involvement or monolobar involvement in combination with liver fibrosis or portal hypertension, and when liver resection is not a viable option. Next. Next, we're going to talk about biliary hematomas and peribiliary cysts, also known as von Meyenberg complexes, also part of the abnormalities of ductal plate malformation. These tend to be less than 1 centimeter, hypodense lesions, and are seen throughout the liver. They may mimic liver metastases, and we need to be aware of them to have it at the back of mind when we see images that look like liver metastases. Then we have the peribiliary cysts, which are similar but appear perihilar and on both sides of the bile ducts and are of smaller size. These are seen mostly in patients with portal hypertension and cirrhosis and may appear as discrete cysts which are parallel to the portal structures or a string of cysts that simulate abnormal bile ducts. For these two, no further workup is required unless there is hepatic fibrosis or in the setting of Caroli disease. Next. So this, the image on the left shows an MRI showing small innumerable cysts, which are the biliary hematomas, which gives the starry sky appearance, while the image on the right showing the cysts that along the biliary tree. Next. Lastly, we'll talk about the mucinous cyst neoplasms, which are extremely rare, previously referred to biliary cystadenoma, or when malignant to biliary adenocarcinoma in previous literature. These are lined by a cuboidal columnar and flattened mucin producing epithelium overlying an ovarian-like hypercellular stroma. Malignant transformation is significant of up to 30%, and that's why it's important for us to recognize them and differentiate them from simple cysts. Next. The image on the left is a comparison of the previous literature, while that on the right shows the ovarian-like stroma. Next. These are almost exclusively in females. They are symptomatic in 86% of patients, with mainly pressure symptoms of fullness and early satiety. They present with either low-grade dysplasia, high-grade dysplasia, or invasive carcinoma. Serum CA and CA19-9 are elevated, but as mentioned before, even in the other least cysts, they are non-diagnostic. Next. The investigations are on imaging, they are solitary, large, well-circumscribed cystic lesions, can be multiloculated or unilocular, and mostly in the left lobe. Next. These are some of the features when dealing with a simple cyst. When identified, then you need to think about whether the patient could be having a mucinous cystadenoma, and in that case, the requirement for further imaging beyond an ultrasound. Next. So the mainstay of mucinous cystic neoplasm is complete resection with negative margins. Aspiration may be attempted, but the recurrence rate is 90 to 100%, and it's not recommended. Next. That brings us to the end of the presentation, and my take-home messages is that in cases whereby you have a pyogenic abscess, you need coverage for amoebic abscess until the diagnosis of amoebic abscess is excluded and another causative agent is identified. There is need to screen for colorectal cancer in patients with pyogenic abscess without any other predisposing risk factor for the abscess. And liver cysts are common, but however, in most cases, no further imaging is needed, no treatment. The mucinous cystic neoplasm carry a significant malignant potential, and surgical excision with clear margins is the treatment of choice. Thank you. Next. Those were my references. And thank you for being patient despite the technical challenges that I experienced.
Thank you very much, Lillian. I think you've done very well under difficult circumstances, and you've kept us engaged and you've kept your time. So well done to that. We're on a couple of minutes to 6 o'clock. Maybe there's time for one or two discussions or questions. I think obviously my background is I'm a surgeon, and it's probably not the most interesting topic for medical gastroenterologists. But nonetheless, maybe we can ask one or two questions. These mucinous biliary cystic lesions that we discussed at the end, we always read about them, but they're exceptionally rare. So it is not a common entity at all. So I think it's like almost like the pancreatic cyst. There's quite a bit of overdiagnosing of them as incidentalomas on CT scans done for, or cross-section imaging done for whichever reason. So they need to be complex, and they need to be central, and they're mostly in females, and they need not to be in young females. Because if you diagnose a mucinous cyst, that means surgery, unlike the pancreas. But it remains fairly uncommon. Any other comments, questions? It seems like, Lillian, your presentation was near perfect. We've addressed some questions as we went along in the chat box. As I scroll through them, I think we have discussed most of them. There's quite a few questions on hydatid cysts and bacterial infections and things around ERCPs. Hydatid cysts is very unlikely to be secondary infected and be pyogenic of nature. Just if you think of on the pathophysiology of them. So normally that's iatrogenic, meaning somebody has perked drained what they thought was something else, and it's hydatid. Perked and drains don't work for hydatids because they've got all these membranes and daughter cysts and things which block the drain, so they don't drain very well. Similarly with ERCPs, if you do an ERCP and you check contrast from the bottom into the cyst, that becomes a secondary infected thing, which is very difficult to treat other than evacuate the cyst surgically for the same reason. You've got these membranes and daughter cysts, and they just don't drain well. These big central cysts with biliary dilatation, the biliary anatomy can be very tricky. That's partly why we do ERCPs for delineate anatomy and for drainage. Physicians need to know about liver abscesses in detail, so maybe absolutely agree. Thank you, Professor.
Hi, Christo, it's VG.
Hi.
I was actually going to say, these ALAs and pyogenic abscesses. So where I am from in Durban, and
Yes.
when I was a registrar and intern, it was exact sort of opposite. The surgeons used to stay away from them, and they used to arrive on our intake.
Yeah, where's
So,
those days?
yeah. This was. I mean, it usually used to end up with internal sort of medicine, and we used to aspirate them. And the ALAs in particular, they were easy. Even the very large ones. I can't remember ever a period where we had to insert long term like. Train. If you aspirate them, and often you hardly have to aspirate them because they respond immediately to your oral flagell. And we give high amounts, 800 stat, and almost immediately, even on that first like a dose, they improve. And there were specific indications for aspiration. So we used to aspirate them, sit there and just aspirate them until they were empty, and you weren't able to aspirate any more, and remove the needle. So I think maybe the reason why it was referred to us is because we were sort of, there was research happening around ALAs in infectious diseases at the time. So yeah.
Majority of the South African literature still comes from KwaZulu-Natal surgical literature. So certainly the most work has been done there. I must say,
Yeah, sure. No. Yeah, that's it, and it's also interesting that we nowadays I rarely hear about ALAs. So it's as I mentioned, when I was a registrar, we'll often have on an intake at least a ALA.
Yeah.
One.
Yeah,
And now it's like very rare.
maybe you can tell me, amoebic disease, is that a notifiable disease? Should be, isn't it?
Yes, it is. Yeah.
So
Yeah.
we spoke about it the other day. We really do that, but in actual fact, it
Yeah.
should trigger some sort of public health inquest.
Yeah. As I said, I think we hardly see it that much. It's still important to be aware of, because I'm sure and I think plenty of these type of patients in maybe our rural areas or semi-urban areas aren't even being referred to our large hospitals. Maybe our family physicians are handling them out there with your oral antibiotics, and they are actually doing fine. And obviously, the overall improvement in hygiene and water, providing people with clean, like in water, has obviously helped as well, and easy access to healthcare and antibiotics at primary healthcare level.
Yeah, absolutely. Thanks for that. I see there's one more question in the chat box. Should all patients with pyogenic liver abscess undergo routine colonoscopy screen for colorectal cancer, regardless of age? I don't think it's routine, but with my insights, I would think if it's cryptogenic, in other words, you do not have a reason for a pyogenic liver abscess, I would certainly consider it, but probably not.
Yeah, no, I also agree, but I would almost always err on the of performing a scope. And it isn't only for colorectal sort of cancer. I mean, it could be any pathology that causes a breach in the chronic epithelium. So tuberculosis of the bowel, Crohn's, undiagnosed diverticular disease can all be a potential seeding. And the other areas that you should also examine for when you do find a pyogenic abscess, and it isn't obviously from some stone in the CBD with acetyl and like is your oral. We've seen abscesses or in affected
dental health
teeth. Yeah, so always look in the like mouth, especially if they have like diabetes, and examine the heart for underlying infective endocarditis. So don't forget to just hear if there's any murmurs. And we've seen all of them. Actually, I've seen infective endocarditis that was undiagnosed. And strangely enough, this patient will present with your right upper quadrant pain. Somebody sends off an ultrasound, and yeah, there's a cystic abscess over there, and then so you should do a complete physical examination, especially if it isn't obvious.
Yeah, we see quite a lot of pyogenic liver abscesses in intravenous drug.
Oh yeah,
it's quite common.
And then obviously over there you still want to examine the heart for your right-sided infective endocarditis.
Yeah. And then even in my short career, I've seen the shift from, I mean, the commonest cause used to be intra-abdominal sepsis, so pleural vein sepsis, diverticulitis, appendicitis, or any sepsis, towards cholangitic abscesses, which is the whole range from stone disease to, again, iatrogenic instrumentation, liver surgery, ERCPs, etc., etc., etc.
Yeah, no, well, I think I ain't gonna say anything else, Christo, but that was excellent.
Good.
And I also see that we way over time.
Yeah, we are. Listen, let's again, last time, Lillian, you can rest now. Thank you very much for sharing this presentation with us. Thank you for all the other contributions, and thank you for listening. Couple more thank yous to Echo University of New Mexico and Echo India team for the support. This session will be recorded, or is recorded, and will be available on the website. Thanks to Gastro Foundation. And do remember the next session is 8 September, same time, 1800, on acute severe colitis. Thank you very much. Thanks for your time.